session. Shall we begin?
Yes, sir.
So can you see my
सर
screen?
यस सर वी कैन ये सब लोग
Okay.
मुझे माइक अपने प्लीज म्यूट कर दें मुझे जाना नहीं आ रहा लोगों तक
Okay. So it was after a long time that I restarted the classes because I thought the students were not interested in having the classes. I'm
सर व्हाई
sorry.
डिड यू थिंक सो
Because the participation reduced to significant less number of people. There were only hardly 3, 4, 5 people coming in. So I thought that people in Pakistan know everything. So I stopped it. But anyways, I wanted to restart it now again. One, I forgot the topic that you suggested. So text me that again. And today I will be talking about borderline personality disorders. This topic was discussed a lot at different forums in Pakistan, and some of my teachers actually did lots of things on that. But one of the, again, candidate or student, a postgraduate resident, asked me that what information needs to be given to the family. And I started thinking about it, why we have problems in giving information about borderline personality disorder to the family and the caregivers and the patients. So if we have to tell it to the patient that you have personality disorder, आपके शख्सियत में खराबी है, then of course it's very difficult for them to swallow it. But if you like to explain it to to them, that this is actually a problem, that is a mental health problem and that needs to be corrected, so maybe they are better. So I will try to cover up this topic in a way what you have to provide the information to the family and the care providers and the patient themselves, rather than just mentioning to you about other things. So borderline personality disorder, a small topic but important. Uh, we all know that if there is a borderline personality disorder, then of course there are multiple challenges associated with managing it. And this is the key for today's topic, right? How we have to see the systemic problems. What should we do during the consultation time? How to manage and again take care of the patients, because these patients are unpredictable, high psychological problems, so high expectations, immediate gratifications, blah, blah. So you all know about those things. Then in Pakistan, unfortunately, we don't have very specific personality disorders clinic or any program where these people can be engaged. Then we have to assess how much they need psychiatry, how much they need psychology, and how much they need other interventions like social interventions. And even providing those facilities in Pakistan is sometimes very difficult issue. We all know that. Then they have compliance issue. They won't listen to you. They won't take the medication. They have negative experiences and they always relate to it. They don't, again, set up the boundaries. So they usually cross the boundaries. Most of the men, they do get too close to the treating female physician. And most of the women, they do get too close, or they expect to get closer to the male physicians treating them. So lack of boundary setting is unfortunately a big challenge in these people. Then training, skills, guidelines, comorbidities, those are multiple other domains that needs to be addressed. It's a difficult situation. And this one at the top corner thing, transference and counter transference, that plays a major role. So if a male physician is seeing a borderline personality disorder female patient who's actually a beautiful woman, then there are lots of possibilities of having these issues. How to address them, how to cope with them, how to make sure that the boundaries are set up, how to make sure that there are no crossing overs, and the outcome and prognosis is good is a very long, challenging situation. But we always feel that the basic problem with again, today's issue is one, what are the theories about how can we explain borderline personality disorder, how to assess it, what is the impact of the diagnosis on the family, on the patient, on the care providers, and then what are the gender biases, and then of course we have to address what exact management strategies we will offer to the patients or the care providers. So we all know that there is a huge gray area in between the borderline personality disorders and the bipolar disorders. If you search the literature, you will come across that there are multiple articles which definitely says that bipolar disorders have too much similarities with borderline personality disorders as well, and vice versa. And sometimes it's very difficult for a treating psychiatrist to demarcate the boundaries between borderline and bipolar. Lots of, again, young women presenting to the psychiatrist with borderline traits turn out to be bipolar, and lots of bipolar patients turn out to be borderline. This is unfortunately a complication. But borderline personality disorder has two phases known as splitting. So they are always black and white thinking, while bipolar has precise manic and depressive episodes. But those manic and depressive episodes are assessed by the physician and the psychiatrist over the period of time. It's not very clear at the first interaction. But this black and white thing can be assessed right at that point in time. It's not much related to the life events, the bipolar, but there is a strong association with the life events. So if you start talking to the people with the borderline, you will find hordes and hordes of evidence and precipitants in their lives which can lead to certain behaviors. They have bipolar patients that have at least one mania, hypomania, or euphoria, or depression, while borderline people are irritable, sad, empty, and anxious. So अंदरूनी एक खला है, एक खालीपन है, एक बेचैनी है, एक उदासी है जिसकी बेशुमार वजूहात हैं, चिड़चिड़ापन है, गुस्सा है. But again, some of these symptoms actually overshadow the depressive episode as well. So we have to be very careful when we are assessing borderline personality disorders. The impulsive nature is actually a chronic symptom in borderline, which usually is not seen with bipolar disorders. Usually, well, sometimes yes, but not most of the time. But impulsivity is a chronic presenting symptoms in borderline. So remember, a key difference in borderline bipolar are three major differences. One, strong association with the life events. Two, again, symptoms which are impulsive in nature are persisting and chronic in borderline. You will be able to see them right from the early teenage till the time they present to you. And they always see things black and white. Either it will be 0 or 100, nothing in between. Too much love or too much hatred. There is nothing in between that. And again, borderline personality disorders, people have distorted image, mood swings, unstable relations, fear of abandonment, impulsive, self-injurious behavior, deliberate self-harm, risky behaviors, feeling of emptiness, suicidal threats. They have suspicious, they have inappropriate anger, they have mental therapist, and they have lack of self-control. So most of them are seeing some psychologist either online or otherwise. So overall, when the borderline people are presenting to you, there is an interpersonal instability, there are cognitive and self-disturbance, there is behavioral dysregulation and affective dysregulation. All these four domains needs to be fulfilled. Again, I won't be focusing too much on the diagnosis and evaluation procedures, but definitely I would like you to know that when you are conveying it to the family and the caregivers, you have to be very careful in using the words. One wrong word will lead to the end of the story, because these people are usually very smart, sensitive, and of course, they are able to judge things around as well. So when you're using the word, you have to tell them that my diagnosis for you is sometimes, which is called borderline. Don't mention the word in the beginning, personality disorder, say borderline. And then this is because of multiple reasons. There are all the symptoms criteria that you are fulfilling. There is interpersonal instability, cognitive disturbances, affective dysregulation, behavioral dysregulation. If you're talking to them in Urdu, then you can use the word कि आपके जो ताल्लुकात हैं उनमें खराबियां हैं, आपकी जहानत में, आपके रोज़मर्रा के अमवार में, बहुत कामों में बहुत सारे मसाइल हैं, आपके मिजाज में उतार चढ़ाव और जो खालीपन है वो बेशुमार है, और आप हमेशा इस चक्कर इस तरह से होता है आपके साथ कि आप मर जाऊं या मार दूं वाली कैफियत होती है. सो हमें इन सारी चीज़ों को देखते हुए जो हमारा डायग्नोसिस है वो बॉर्डर लाइन है, और इसमें शख्सियत के मुख्तलिफ जो मराहल हैं उसमें खराबी पैदा होती है और उसकी बेशुमार वजूहात हैं. सो हम आपको इसके बारे में मज़ीद बताते हैं. Using personality disorder with an educated person will definitely raise concerns. So again, this is the reason why I'm saying that you don't have to lie, you don't have to cheat, you don't have to be, again, but use the words carefully. What I do is that I use the term borderline, that you are having borderline and you have some personality issues that needs to be addressed, and these are the symptoms that I have assessed leading to your diagnosis. And again, there are different types of borderline personality disorders like petulant, discouraged, impulsive, and self-destructive. Usually, little bit of everything is seen as well. So they are petulant, unpredictable, mood swings, passive aggressive, and a need to feel in control. They are discouraged, fears of being abandoned, neediness, emotional mood swings. They are impulsive, bringing risky and aggressive behaviors, and they are self-destructive, which are using, slashing their arms, slashing the limbs, cutting their body, picking their skin, pulling their hair, things like that. So those are four different kinds. And again, you can relate all of these things to the patient as well when you're talking about how to explain it. It's a very nice picture, black and white. So as I use the term black and white, they always see things black and white. Pura, 100% ya zero. So personality disorders, they have impulsive and risky behaviors, driving unsafe, having sex unsafe, gambling sprees, illegal drug use, चर्च पी लेते हैं, पार्टियों में जाते हैं, अल्कोहल ले लेते हैं, शादीशुदा होने के बावजूद sexual relationship extramarital बना देते हैं, and they're very smart in concealing them as well. So which is again something very tricky and problematic. And wide mood swings. एक मिनट में इतने अच्छे थे कि आइसक्रीम खिला रहे थे सारों को, और दूसरे मिनट में इतना गुस्सा आया कि सब कुछ छोड़ छाड़ के गाड़ी भगा के किसी तरफ निकल गए. So those kind of things, they are trickier. And again, the idea is not to again may mention to you about the symptoms in today's lecture. It is idea is to what needs to be conveyed to the family or the care providers. So DSM-5 gives these major criteria for 5 of the following symptoms, and you would label them as borderline. DSM-5, the new one. I should have used ICD-11, but I could not find a slide for it, so I used this one. Abandonment reaction, छोड़ जाएंगे, तन्हा रह जाऊंगा. अनस्टेबल रिलेशनशिप, एक मिनट में अच्छे, दूसरे मिनट में शदीद खराब, अनस्टेबल सेल्फ इमेज, मैं ठीक लग रही हूँ, मैं अच्छी लग रही हूँ, ये कोट ठीक है, ये बटन ठीक है, ये पेट तो नहीं निकला हुआ, थिंग्स लाइक दैट। देन इम्पल्सिविटी, recurrent suicidal behavior, emotional instability, paranoia, inappropriateness, and chronic feelings. मुद्दत हो गई, खुशी नहीं मिली, नसीब हुई, ये इस these type of dialogues, they are very common, and unfortunately those are the dialogues that will lead you to the clues that okay, fine, this may be a borderline. It may be because of the primary psychiatric morbidity or something else, but this is important. Now, this is the important slide as far as the informational care is concerned. So when you are explaining it to the family members or you are explaining it to the patient, this is the slide that you should be talking about. One, risk related to context and vulnerability factors. कौन से ऐसे लोग हैं जिनको borderline personality disorder होता है? If you'll be able to find sexual and physical abuse, maladaptive parenting, experience of peer victimization, and attachment disorganization. That is the key. Now, during the development phase, if you would be able to find, but these are the key four things: sexual abuse, physical abuse, maladaptive parenting, experiences of peer victimization, and attachment disorganization. These are the key. So when you are discussing it, you will tell it to the family and the care providers because there was some maladaptive parenting. माँ बाप के झगड़े, उनके आपस में तजाद, उनकी आपस में ना बननी, उनके मिजाज में कुछ मसाइल होने जिसकी वजह से बच्चे का इफेक्ट होना, इन चीजों ने यहाँ तक लेकर आए. So easier to explain it to the family then. So the four things: sexual abuse, of course, if you'll be able to find it, then it will be much easier to explain it to the patient that your brain is functioning like this because of some traumatic life events like sexual abuse. That is easier. But experiences with the peer victimization, we usually don't ask them. But in borderline personality disorder, it's very, very important. And attachment disorganization. So the characteristics in the genotype. Now, some of these people, they inherit these traits, which is 60%. It's polygenetic, and the gene and environment plays the role. So you can explain it to the patients that because अल्लाह ताला ने आपको ऐसा बनाया है, मौरूसी तौर पे आपने कुछ चीज़ें अपने वालिद और कुछ चीज़ें अपनी वालदा से ली हैं, जिसके जमा होने से आपके अंदर इस किस्म की चीज़ें बढ़ गईं. इसमें कुछ और दिमागी तौर पे रतूबतें हैं, जिसमें पॉलीमॉर्फिज्म ऑफ सेरोटोनिन ट्रांसपोर्टर जीन, पॉलीमॉर्फिज्म इन डोपामीन ट्रांसपोर्टर जीन इन्वॉल्व है, जिसकी वजह से आपके दिमाग का जो सामने वाला हिस्सा है वो सही तरीके से काम नहीं कर रहा और उसमें कुछ ऐसे सर्किट मौजूद हैं जो आपकी सोच को बार बार वहां घुमाते हैं और आपके जिस्म के अंदर ऐसे मादे पैदा होते हैं जिससे आपके अंदर गुस्सा, चिड़चिड़ापन और अपने आप को या लोगों को नुकसान पहुंचाने वाली कैफियत बनती हैं. I hope I make sense. And then intermediate endophenotype, paroxysmal negative social cognitive bias, coordination, hypermentalizing, impulsivity, emotional dysregulation, and then phenotype. So endophenotype जो कि अंदर से चीजें निकल रही हैं, and again phenotype जिसका expression रोजमर्रा की चीजों में हो रहा है. That interplay gives you the problem. And that is unfortunately the main issue. But of course, we can do a lot about it. We'll be able to make sure that you have a secure attachment. We want to make sure that your relatedness, your social issues, your interpersonal skills are developed. We want to make sure that your brain starts functioning in a normal way. and then we will move forward. So explaining all of this stuff to the patient and the caregivers, you have to give them a hope that you are capable of treating all of these issues, right? Unless or until you do that, the explanation fails. So as I told you, they are very smart people and they want to know. Now, this is known, and you will be able to find this for lots of borderline personality disorders. And I'm telling you these findings because then it's easier for you to convey the information to the patient to convince them to take the treatment. Like borderline personality disorder, people have low oxytocin level. They have poor parent-child bonding. They have insecurely attached child. There are genetic factors, alleles, as I told you, serotonin gene transporter system and dopamine gene transporter system. And these factors, along with oxytocin levels, along with multiple attachment issues and genetic factors, play a vital role in development of a disease which we call as borderline personality disorder. So this is how you will convey it in the situation when you have to give the information. Lifetime morbidities. Now this slide is bad because I picked it up from somewhere. But as you can see that the mood disorder makes 96% as a comorbidity in borderline. So this means that bipolar, major depressive disorders, hypomania, mania, cyclothymia, all are very common, 96%. MDD, 86%. Anxiety disorders, 88%. Panic disorder, 46%. PTSD, 50%. Substance abuse, 65%. Eating disorder, again, less, but still very significant, 26%. So you see high comorbidities with the primary psychiatric disorders, which makes sense, and you have to give them medication to treat that as well. Now, what medication? Of course, it's not just the medication. It's among all other things, the medication. But to make sure that the patient understands, this is how you will proceed. So the acceptance for the diagnosis is there. And then again, comorbidities with ADHD, autism, bipolar disorder is very much there, and it's complicated. Good psychiatric management for borderline. Now, how will you explain the management strategies to the patient and to the care providers? One, first you will tell them that you have made the diagnosis, it's borderline, and it is unfortunately, so you see, explain the diagnosis in non-pathologizing terms, connecting it to the issues in the patient's life in a way that conveys hope. Involve family in the education when appropriate. So you have to use words carefully. So very carefully, very optimistically, very hopeful, but of course conveying your information to them as well. So as I mentioned, borderline, multiple etiological factors. If you'll be able to find one, easy to explain. Otherwise, genetic factors, again, interpersonal factors. Then clarify what will you do, how will you proceed with the treatment, a predictive course of treatment line. Be real, speak directly, openly and honestly. Goal setting, then you have to set up the goal. Okay, fine. आप हर 2 हफ्ते बाद, 4 हफ्ते बाद, 6 हफ्ते बाद मेरे पास आएंगे. आपके जो भी मामलात इर्द गिर्द हो रहे हैं वो आपने मुझे ऑनेस्टली कन्वे करने हैं. जो भी मसाइल बेहतर हुए उनके बारे में भी बात करनी है, लेकिन जो मसाइल इसमें कॉम्प्लेक्सिटी पैदा कर रहे हैं उनके बारे में बात करनी है. हम कोशिश करेंगे कि हम आपको साइकोलॉजिस्ट के साथ और कुछ लोगों के साथ ऐसे राब्ते में रखें कि अगर आपको कोई भी ऐसी सिचुएशन दरपेश आए तो आप उनसे राब्ता कर लें, उनसे डिस्कस कर लें, इससे पहले कि आप अपने आप को या किसी और को नुकसान पहुंचाएं. ये बात ध्यान में रहे कि आपके पास ऐसा एक नंबर हो जहां आपको थोड़ा सहारा, तसल्ली या एक्सप्लेनेशन मिल जाए जब तक कि आप हम तक नहीं पहुंच पाते. और इसके साथ साथ हमारी कोशिश होगी कि जो भी अद्वियात या दूसरी ऐसी चीज़ें आप इस्तेमाल कर रहे हैं नशावर, उनके लिए भी हम कुछ ट्रीटमेंट स्ट्रैटेजीज बनाएं और इलाज मुआवजे में बेहतर करें। कुछ हम आपको दवाइयाँ दे रहे हैं जिसके आपसे आपके मिजाज में बेहतरी आएगी और जो उतार चढ़ाव मिजाज का है वो भी बेहतर होगा, और हमारी कोशिश ये होगी कि 3 से 6 माह में चीज़ें कंट्रोल में आ जाएं। Now, this is the information that you have to convey it to the family and the care provider. So case formulation, interview with the patient, family, psychiatric evaluation, shared decision making, treatment planning, psychoeducation, crisis anticipation, motivation, execution of the selected treatment intervention, and termination, of course, a process of social rehabilitation. Good psychiatric management plan, as I mentioned to you earlier, the same is repeated here, but with one more addition: interpersonal hypersensitivity. That is again too much important. An explicit and consistent effort to connect the patient's emotions and behaviors to interpersonal stresses. लोग आमतौर पे वी जस्ट डू द ब्लेम गेम, उसने मेरे साथ ये किया इसलिए ये हो गया. सो यू हैव टू एंड अप दैट एंड you have to make sure that you as a victim in the villain role should go away and make things harmonized. So that is important. Key to the treatment: emotional regulation, distress tolerance, mindfulness, and interpersonal effectiveness. Now, the psychologists have used these amazing terms to highlight one thing, which is DBT, dialectical behavior therapy. So one, dialectical behavior therapy; second, cognitive behavior therapy; third, interpersonal therapy. So three types of therapies are usually initiated along with the management pharmacological intervention according to the comorbidities. Now, DBT involves these four factors: emotional regulation, distress tolerance, mindfulness, and interpersonal effectiveness. I will briefly explain them to you. Emotional dysregulation: हमें अपने जज्बात और एहसासात की इंटेंसिटी और स्वेरिटी का एहसास हो. किस वक्त हम गुस्से में हैं, किस वक्त हम उदास हैं, किस वक्त हम मायूस और परेशान हैं, और किस वक्त हम एंग्शियस हो रहे हैं. The ability to effectively manage and respond to emotional experiences is the key. That is emotional regulation. When our emotion control us, we feel, act, and only then think. बाद में ख्याल आता है, ओ ये गलती कर दी. So this is the common thing with the borderline. So we have to train them to understand that this emotion, if it would have been checked earlier, then the outcome would not be the way it happened now. So that training is emotional regulation. So you have to give them various emotional states, make them understand the red zone is very tricky and bad for you, and you should not end up anyway in red zone. Yellow zone is also tricky, but blue and green zone. The best is the green zone, that you should stay relaxed, calm, focused, content, and happy. But बात वही है, अगर खुशी मेरे इख्तियार में हो तो मैं दुनिया का खुश तरीन इंसान हूँ, कभी दुख को करीब ना आने दूँ. So understanding and making it happening is a little bit difficult. Mindfulness, knowing what is happening while it is happening without preference, that is mindfulness. And 12 ways to practice mindfulness: brain breaks, breathing exercises, check with your emotions, use senses to observe an object, take a mindful walk, recite positive affirmations, कुरान पढ़ें, हदीसें पढ़ें, नमाज पढ़ें, थोड़ा उस ध्यान अपना बटाएं. Spend time writing in a journal, mindful listening to the music. अब म्यूजिक सुनने की बारी है तो रॉक एंड रोल. Again, if you feel relaxed with it, I don't mind, but it depends what music you like. Practice yoga or stretch, then drawing, painting, reading, and again, spend extra time outside in the nature. यहाँ वेस्ट में ये बड़ी कॉमन प्रैक्टिस है खैर पाकिस्तान में भी ये 14 क्लास कुछ करती है, मरी निकल गए, कगाना निकल गए, मुख्तलिफ इलाकों की सैर कर ली, विच डेफिनेटली इज अ गुड प्रैक्टिस. Distress tolerance, tip skills, temperature, intense exercise, paced breathing, and paired muscle relaxation. All of these psychological phenomena, tip, temperature, आप अपना दिमाग का जो है ना वो हरारत बढ़ने ना दें. इंटेंस एक्सरसाइज, इतना अपने आप के जिस्म को तोड़ें फिजिकली एक्सरसाइज से कि आपकी सोचें पीछे रह जाएं और जिस्मानी थकावट ऊपर आ जाए. पेस्ड ब्रीदिंग, सोच के केयरफुली कॉन्शियसली कंट्रोल्ड ब्रीदिंग करें और उससे फिर मसल एक्सरसाइजेज और रिलैक्सेशन करें. डिस्ट्रेस टॉलरेंस स्किल्स, यूजुअली टिप इज द की विच कैन हेल्प पेशेंट्स. Interpersonal effectiveness. This is the unfortunately most difficult one. Self-respect, keeping and maintaining relationship and getting what we want. How does CBT work for borderline? Now, you people might be having lots of sessions about that as well, because I know मेरे उस्ताद फरीद गुनाह साहब ने बहुत सारे सेशंस किए थे across Pakistan related to borderline, which were very effective. अगर आपने सुने हो तो they were helpful. नहीं सुने तो उसकी कहीं से रिकॉर्डिंग वगैरह लेके सुन लें, मजीद एक्सप्लेनेशंस मिल जाएंगी. फिर भी कोई मसला हो, let me know, I will teach you more. But this was basic outline. And the last thing, antidepressants, mood stabilizers, antipsychotics, benzodiazepine, and naltrexone have evidence in management of borderline personality disorders. I won't go into that detail because people then start feeling that I'm more biological oriented. So this is it. Any questions so far? Why do the symptoms start to settle after 40 years of aging borderline? किसी भी पर्सनालिटी डिसऑर्डर में सिम्टम्स, किसी भी पर्सनालिटी इशू में सिम्टम्स 40 के बाद क्यों सेटल डाउन होते हैं? मल्टीपल रीजंस फॉर दैट. Biological reasons, I tell you, aging process, brain neurons, they start settling down and making you more calmer as you grow older. अक्सर ये कहना होता है जब मर्द बूढ़ा और इंसान बूढ़ा होता है तो बच्चा बन जाता है. सो बचपने में बहुत सारी चीजों का पता नहीं चलता. जैसे जैसे ये हार्मोनल चेंजेस सेटल डाउन होती हैं, वो न्यूरोकेमिकल इम्बैलेंसेस करेक्ट होते हैं, तो आप टोन डाउन होना शुरू कर देते हैं. कुछ लोग उसको बर्नआउट फिनोमेना भी बोलते हैं कि जी आप एग्जॉस्ट होना शुरू हो गए अपनी हरकतों से, नशा छोड़ गए, घर में बस गए, बच्चों की जिम्मेदारी ले ली. सो लॉट्स ऑफ थिंग्स आर हैपनिंग इन लाइफ एट 40. बच्चे जो हैं स्कूल जाने वाले जो होते हैं वो मना करना शुरू करते हैं, बाबा सिगरेट नहीं पीनी. आपको थोड़ा रिस्पॉन्सिबिलिटी की होती है कि जी पैसे घर में देने हैं, बिजली का बिल कहाँ से आएगा. सो आप उन चक्रों में भी 40s में ज्यादा पड़ जाते हैं. फिर आपको आगे की फिक्र पड़नी शुरू हो जाती है कि बीमार हो गई, दवाई कहाँ से आएगी, डॉक्टर के पास.
I found this on the web for personality issues and the symptoms jealous guy by multiple reasons. For the biological reasons, I tell you, aging process, brain neurons
on its own. Sorry about that. Okay, so ये चीजें थोड़ी सी जो है ना उसके वजह से 40s के बाद there are definite scientific evidence for that as well. I will definitely use that if needed, but for the timing, this is how it is. Any other question? How to lower expectations of family regarding the prognosis? As family is in extreme. क्वेश्चन गायब हो गया. लेकिन छोटी सी बात देखो, एक्सपेक्टेशन फैमिली की उस वक्त हाई होती है जब आप उसको हाई करते हैं. मैंने पहले कहा कि अगर आप अपने अल्फाज का चुनाव एहतियात से करें तो फैमिली की एक्सपेक्टेशंस हाई नहीं होती. चाहते सारे यही हैं, टीका लगे तो मैं सेट हो जाऊं, लेकिन आपको वो एक्सप्लेनेशंस जो मैंने सारी दी हैं वो फैमिली को बताना है कि जो असाबी, समाजी और जहनी प्रेशर इनके ऊपर है उसको वक्त दरकार है ठीक होने में. इसको 3 से 6 माह लग सकते हैं. कुछ लोग 3 महीने में बेहतर हो जाते हैं, कुछ को 9 महीने से 1 साल भी लगता है. और ये सारा मुनसर इस बात पे है कि आप कितनी बाकायदगी से इनका इलाज करवाते हैं और डॉक्टर के मशवरे पे चलते हैं. सो एक तरफ उनको इंसाइट देना, दूसरी तरफ उनको एजुकेट करना, तीसरी तरफ रियलिस्टिक अप्रोच है, दैट इज इंपॉर्टेंट। और कोई सवाल? बस थक गए? ओके, सो इट वाज नॉट टू बैड, 40 मिनट्स। I tried to provide you the informational care that you needed.
सर एक और क्वेश्चन है चैट बॉक्स में।
Oh, okay.
किसी ने लिखा है, and that's a very important question.
Okay, chat box में question है, how to handle people in your friend circle who have borderline traits, not fitting into the criteria of disorder, but have traits from all categories, from all cluster B. Okay. How to handle people in your friend circle. दोस्त बनते हैं, इसकी लंबी साइकोलॉजिकल एक्सप्लेनेशन है, ठीक है। ये किसी वक्त मैं डिटेल से वैसे बात करूंगा, लेकिन मैं छोटी सी मुख्तसर ये बात करूं कि हम दोस्त भी अपने जैसे लोगों को बनाते हैं, और जहां दो बॉर्डर लाइन मिल जाएं वहां पटाखे लड़ाइयां होती हैं। सो दिस इज अनफॉर्चुनेट बट दिस इज ट्रू। लेकिन ऑफ कोर्स दिस इज